Unfortunately, viral and bacterial throat infections cannot be clinically differentiated. Hello, my name is Said Ali Safizadeh, and in this video I will be talking about my research. Let me just grab my script. Alright, let's do this. Because we cannot differentiate viral and bacterial throat infections clinically, we have to do a culture test, which is the gold standard test for diagnosing streptococcal pharyngotonsillitis, or in other words, bacterial throat infections. The downsides of cultures are that they take around 48 hours to call, and by this time the physician has already prescribed the antibiotics to the patient, and this leads to an unnecessary rise in antibiotics-resistant bacteria. A faster way for physicians to decide whether to prescribe antibiotics or not would be to use something called a rapid antigen test. However, recent research has shown that the sensitivities of these tests are usually very low and around 70%. Our objective was to assess the clinical reliability of quickvue dipstick streptococcus A test in predicting acute streptococcal pharyngotonsillitis in children. Our inclusion criteria consisted of children under the age of 16 with fever, acute catarrh, inflamed throat, and those patients who had not taken antibiotics before the test results were known. Following that, we took a paired throat swab from these patients. And as you can see here, one of them will go for a culture test, while the other one will go for quickvue dipstick streptococcus A test. Our results showed a staggering 100% sensitivity and an unbelievable 99% specificity, alongside a 96% positive predictive value and 100% negative predictive value. We conclude that the quickvue test is a perfect way for treating physicians to decide whether to prescribe antibiotics or not to children with pharyngotonsillitis. Also, it would prevent unnecessary healthcare costs as well as reducing the risks of treatment.